You're the guys that traditionally you're the ones saving teeth. So now if you start doing implants, means that you're going to have to extract teeth to put the teeth in, right? So in the old days where periodontists don't do implants, they will hang on to this tooth with great 10 mobility, if there's such a thing. And we wait until when the patient one day sneezes and then the tooth flies out in the mouth. Right? That's what the periodontists do, right? They hang on to the teeth, and they are the final protector of the tooth. But with implants, increasingly, we see periodontists saying, oh, this one got such deep pocketing, it's impossible to maintain, it's a grade 2 mobility, and this is not very motivated patient, or maybe, you're better off with extracting a tooth and doing implants. So there are variations in practice like this, and looking through the evidence and making a statement on it will be a good thing to do. At least that's what we as a group we felt. Okay. All right, so multidisciplinary participation is essential to ensure proper evaluation and interpretation of specialty-specific evidence, relevance to the realities of their everyday practice, and ultimately ownership and cooperation of all stakeholders. The last thing we want to do is to come up with a set of guidelines, even if it's like very highly based on evidence, and that but people feel alienated from it and they do not adopt it, and they still carry on doing whatever they are doing, and there's no impact on the way dentists practice implant dentistry, then that will be a waste of the effort they've put in over the last 3 years. So we wrote in, even though the college is an organization of specialists, we wrote in general dental practitioners to make sure that the voices are heard, and we also want to see how a general dental practitioner view the practice of implant dentistry. So that impact, that perspective is very important, because the bulk of the people out there that we hope that will adopt the recommendations in our guideline will be general dental practitioners. Because after all, on the dental specialist register, there's only 306 dentists, and there are 1,600 over dentists on the dental register. So we hope to have as widespread as possible an adoption of these guidelines. Right, so these are my work group members. At the end here, I summarize it. I admitted right from the start I'm a bit biased. So in the selection of the different specialties, there seems to be a little bit more OMS. So in total, we have 6 oral maxillofacial surgeons, 5 prosthodontists, 5 periodontists, 4 general dentists, 1 orthodontist, and 1 endodontist. Now, the orthodontist is not chosen because there is an orthodontic application. So we're not dealing with orthodontic anchorage device. Right? It so happened that she's an orthodontist, and so happened that at that time, she's a staff in MOH, and so happened at that time that MOH sponsored a few of us for a CPG writing workshop that's organized by the Scottish the sign group in Singapore. So she was trained in the methodology of CPG writing, and so I thought it's important to incorporate her as a work group member, because the majority of the rest of us only have that one-day exposure to CPG writing in the workshop organized by MOH. And we have 1 endodontist. Again, although I heard that there's a trend in the US of endo residencies offering implant dentistry as a module within the residency. I'm not saying that whether it's a right thing or a wrong thing, but since we felt that there's a need to evaluate or compare the efficacy of extracting a tooth with irreversible pulpitis and putting an implant compared with actually doing the implant and saving the tooth, then I felt that we need to have an endodontist on board, right? So these are the topics that we have chosen. Today, we will highlight a few of these, 4 of these topics that we have worked on. Implants in irradiated bone. Now, while this is has a relatively narrower impact on the, in terms of the number of dentists out there that's actually treating patients who have gone through irradiation. The consequences of wrong selection of patients who have gone through, or improper management of these patients, can lead to catastrophic consequences. So that justifies itself a place as one of the topics that we choose. Because if a patient end up coming in for an implant and with ending up with osteoradial necrosis that cannot be treated and his jaw start rotting away, then it has grave consequences on the individual, right? On the issue of bisphosphonates, I think the literature is quite clear on intravenous bisphosphonates, but there's a lot of gray area on oral bisphosphonates, and we thought that, and oral bisphosphonates affects a lot more people than intravenous bisphosphonates. So this addresses largely a lot of the people, typically postmenopausal women who've been on oral bisphosphonates for prophylactic management of osteoporosis. So we felt that this is also a topic that is worth considering. Periodontal disease is fast replacing dental caries as a prime cause for tooth loss. So we need to look at whether implants in patients with controlled periodontal disease do just as well. Of course, if the periodontal disease is not controlled, then it's a no-brainer, right? We would not place implants in these patients. But in a motivated patients who have gone for periodontal therapy, is controlled perio condition, some teeth has been lost, we place implants on these patients. Do we expect a similar success rate with patients who have not lost teeth through periodontal disease? So this is another area that we have addressed. Smokers, there's a lot of smokers around, and what is the impact of smoking on dental implants? That's also something which we need to consider. Narrow diameter implant has been controversial, and later Myra will speak on narrow diameter implant, and she will elaborate more on that, so I won't go too much into it. Implant versus endo, as mentioned before, implant versus a bridge. So instead of a single tooth implant, you can do a 3-unit bridge, right? The good old 3-unit bridge. So we want to see, are we really doing the patient a favor by recommending a single tooth implant over a 3-unit bridge, and what does the literature tells us? And then there's a lot of grafting that's been done today. No longer things like sinus bone graft is no longer a procedure limited to being practiced by oral surgeons. General dentists have been doing these procedures quite a lot, and we want to have some kind of look at evidence out there and makes a recommendation as to what how all these sinus bone graft function with implants, right? And then the issue of connecting implants to natural teeth. Do implants behave biomechanically in the same way as natural teeth? They probably don't. And is there an important enough a difference that we cannot link the two together, or should we keep them separate, right? And also the placement protocol I mentioned early on. Now, if you read Thursday's Mind Your Body, they mix up some of the data that we discussed with them. They were actually making inquiries about placement protocol, as in an immediate placement. That means we extract the tooth today and immediately place in an implant, which is different from immediate loading, which means that we put in an implant and we put a crown on it. But I don't blame the reporter. As a layperson, it's a bit difficult to differentiate what is immediate loading and what is immediate placement. So there are differences. It means different things, and the success rates are slightly different as well, right? So this guideline provide critical appraisal and synthesis of the current scientific evidence, and we make recommendations on best practices. And well, it's a challenge to the health service to implement. Let's see what MOH does. Just to summarize, to give you an overview as we go through the questions, the next 4 questions that my co-workers will present. Sorry.